Hi, I'm Dr. B, psychiatric nurse practitioner with over 20 years of clinical experience and created choice mapping. Today I'm talking about and doing a series on the problems in mental health care and treatment, and specifically today, the non-standardization of mental health treatment. Specifically, psychopharmacology, and then I'll do another one on the therapy component. I'm a little nervous about this topic because it's not my strength. I think there are many academically based-minded, scientifically minded neuroscientists that truly understand the receptors in the brain and the psychopharmacology. But what I can tell you is that there is a significant problem in our system of how we are treating mental health symptoms. So, for example, if you were to have a cardiac problem and you were to go to a cardiologist in one town and get an opinion, and go to a cardiologist in another town and get an opinion, you probably are going to get a very similar experience, give the same, recommendations for medications. It's fairly standardized other, specialties. But when you go to a psychiatrist, again, this is nerve-wracking for me to talk about this because I'm basically saying that the field in which I practice in, the system is broken. There's pretty significant problems. And when it comes to the specifics on psychopharmacology, I want to refer to Dr. Stephen Stahl's work and all of his circuits and receptors. But what we do know is that the way that we diagnose and treat is based on this book called the DSM-5. And the DSM-5 is basically just a cluster of symptoms. It doesn't actually correlate with neurobiology. And the Food and Drug Administration is who approves our medications. And when a medication goes to get approved, it has to have a diagnosis it's asking to be approved for. It can't be just approved for certain symptoms. And so it has to say, okay, we're going to seek approval to be the treatment for depression or the treatment for bipolar. And then they have to prove that in scientific studies, right? So this is all good if you're talking about a very concrete system like cardiology. But when you're basing everything on the DSM-5, which is just a cluster of symptoms not directly associated with the circuits in which these medications work in the brain, it becomes a problem. And so the FDA approves a medication for a very specific cluster of symptoms. However, for you, your cluster of symptoms may be very different than someone else's cluster of symptoms. But as a practitioner, I'm supposed to only prescribe things that are FDA approved for that diagnosis. So if you can see kind of what's going on here is there's this cluster of symptoms, these medications that can only be approved specifically for a cluster of symptoms. However, each of us are very individualized in how our mental health is being expressed. And so it really limits us in our psychopharmacology. It kind of forces us to do things off-label. Some people feel comfortable in that, some people don't. Being able to justify that with neurobiology, again, referring back to Dr. Stephen Stahl. And if we're allowed to show his picture, if not, we can just send a link to it in our comment section where he has done extensive work on these circuits in the brain. And so if you look at depression, for example, major depressive disorder, which we have medications that are approved for major depressive disorder, that cluster of symptoms, there's a cluster of symptoms that are associated with it. But if you look at each of those symptoms associated with depression, the area of the brain in which the malfunction is occurring is different. But the medication that we prescribe is probably only targeting one of those areas. So some of our new medications out are targeting several areas, but again, this conflict between the diagnosis and the treatment option. So I'm going to give an example. you have a 16-year-old that comes in. They're adopted. There was trauma prior to adoption, and they are presenting with cyclic moods, depression, anger, what could be manic behavior. And if we looked at the DSM criteria for reactive attachment disorder, post-traumatic stress disorder, or bipolar disorder, this teen would be fitting symptoms in all of those categories. So which one is it? Or is it all three? And so this is what we are trying to do when we diagnose. And this is why the actual diagnosis is not as important as finding what makes you better, okay? Because this video is about that there's a problem in the way that we diagnose and in the way we treat. So we have this 16-year-old that's presenting with these severe fluctuating moods, manic or risk-taking behavior, which you can get in reactive attachment, you can get in PTSD, depressed mood, anxiety, you can get in all three. And we are trying to find a medication that would work for them. So maybe we've tried a few, and you know, it's always safe to start with serotonin reuptake inhibitors. Those are approved for depression. There's not much pushback to use it in all mental health disorders, but those are not working. But there's this medication, this new medication out that works on some serotonin receptors, also regulates dopamine. So if for the risk-taking behavior and some of the reactivity, as well as works on the alpha receptors, which helps with impulse control and some of that reactivity that you might get with PTSD. This medication, I'm thinking, this would be perfect for this 16-year-old that's presented this way. But I can't give it because it's only FDA approved for the adjunct treatment of major depressive disorder. So these are the problems that we come up, that we face every day in trying to find medications to treat whatever symptoms are coming up. So the non-standardization, when I say that, when it comes to psychopharmacology, is that, one, the DSM and the cluster of symptoms, the way the FDA approves medications, and then in which era you went to school to learn about that psychopharmacology, because this is kind of the emerging field, and there's so much to be learned and to understand. And we also know what else complicates it is that this, what I call the 50-50 rule, 50% feelings, 50% function, or when I say function, things that we can address with medications, biochemical things in the brain that we can adjust with medications. So you may not get the same advice or recommendation going to two psychiatrists and even in the same town. And so I again refer back to Dr. Stephen Stahl's work in standardizing treatment based on circuits and receptors, and get into a good therapeutic environment, with choice mapping. Choice mapping gives you that solid foundation so that you can be empowered to be able to control your feelings and your thoughts, combine that with the right medications, and I do believe that you are mentally strong.